I want to say thank you all for showing up. You are definitely kudos to you guys. And that means you're all passionate about this topic. And it's something very relevant in the industry that's going on right now. As you know, we are seeing more and more clinicians leave the industry and burning out. So today we have a discussion about burnout, breaking the cycle, a roundtable on retention strategies. And we have put together a great list of panelists for you to represent all the different people at PPS here and all the different organizations. We have a health tech leader. We have somebody from the largest enterprise organization out there to a mid-enterprise to a mom and pop. So hopefully giving a good representation of what's going on in the industry, being able to relate it to all of you. And some experts in the field who have been working hard on this and putting different strategies in their clinics, in their organizations to really combat burnout and to make sure they're creating great cultures for everybody that's working there. So we have Pedro Teixeira. He is an MD, PhD in biomedical informatics and is the co-founder of Prediction Health, which is now a part of Prompt and known as Prompt Sidekick. Pedro, it's a pleasure to have you.
Happy to be here. Thanks all.
And we also have Elena Marino, who is a founder and owner of Marino Physical Therapy, which is a quality mom and pop in Tennessee, as well as an adjunct professor at South College and Lincoln Memorial University. Thank you, Elena, for being here. And we have Mike Manzo. He's the co-founder and CEO of Atlantic Physical Therapy Center, which has grown from one clinic to more than 30 locations across New Jersey. Mike, thank you. And we have Larry Benz. Larry is the founder of Confluent Health, a national network of over 1,500 private physical therapy practices, and a lifelong advocate for elevating the PT profession. Thank you, Larry. And let's just start with a poll of hand. We want lots of engagement from you guys. Please feel free, even during the conversation, if you have something to say, feel free to raise your hand. We will do Q&A afterwards. But for all of you out here today, how many of you are experiencing burnout in your staff? Could be your clinicians, your admin, but just let's give a show of hands. Great. And are you seeing more burnout now than 10 to 15 to 20 years ago when we were all treating back in the day? Show of hands. Okay, awesome. It's been coming. We've been seeing it. There's been signs. It's not something that just popped up this year. There's been a lot of research out there and a lot of red flags. So in 2023, APTQI put out a report stating that 47% of healthcare workers plan to leave their positions by 2025. Then in 2024, outpatient PT clinics, there was a APTA workforce report that showed 9.5% vacancy rate in outpatient PT clinics, and that's double the US national average. Then come to 2025, the search for non-clinical physical therapy jobs on LinkedIn increased by 38%. We see that in our health tech company where we put out a role for a customer success manager and say looking for a clinician, and the amount of applicants is just hundreds. It's crazy, all these clinicians out there just looking for that non-clinical role. And this is so much that the US Senate drafted a bipartisan resolution labeling burnout across the health profession as an epidemic and urging targeted mental health resources. So with that, we did do a survey in 2024. It was a Prompt Clinician Transition Survey. We took all of those therapists who transitioned to non-clinical roles and asked them why. What was the reason? So low growth opportunities and low pay remain the biggest reasons that we saw why clinicians were leaving. Nearly 9 out of 10 cited limited career growth. About 3/4 pointed to insufficient salary or benefits, and 2/3 said emotional burnout played a major role in their decision to step away. And that was the biggest portion of clinicians that were transitioning were around a 5 to 7 year mark of experience, and they were leaving for non-clinical traditional roles. So we then did a survey in 2025 looking at all the different practices, not just Prompt practices, it was throughout the country. It was a growth survey, and we found that just over half of practices reported burnout-related barriers to growth. We saw admin overload, retention struggles, staffing shortages, and stagnant pay as the top causes. And only about 1 in 2 practices were measuring staff happiness on a regular basis. So that means that about half of the industry isn't meaningfully tracking clinician well-being and burnout. So with that, we're going to go into the pressure and root causes and ask our panelists and find out from them, what do we think is happening here, what burnout means, and what are the main reasons of what they're seeing in their own organizations. So Larry, I'd love to start with you. If you can tell me, let's just set the stage and define what burnout is and how that truly resonates with the field.
Thanks, appreciate it, and appreciate all of you showing up this morning. I think it start out trying to make this sort of practical for reasons that'll become obvious. Burnout is not an ICD-9 code. It is not a medical diagnosis or a disease. Burnout is not a diagnosis, DSM, the Statistical Manual of Mental Disorders, version number 5 or whatever those crazies are up to in their version numbers, but it is not a code with that. Psychiatry jokes don't work early in the morning, I guess, but in any event, that's what it's not. But what it is considered by the World Health Organization is an occupational phenomenon. And, you know, as many of you know, a lot of the therapists land in your clinics the first day and they're already, by classical definition, burned out. So burnout really derived from the medical research literature. The predominant survey instrument is called the Maslow Burnout Inventory, or MBI, and it defines it on 3 levels. Number 1 is emotional exhaustion. So there's this emotional aspect of it. They are no longer feeling enthusiastic about patient care. They have an inability to cope kind of with the demands of the patient. They're not marrying the emotions of it. There's a clear lack of it. And later on, if we get into some of the warning signs, we'll go a little deeper there. The second dimension is what they refer to as depersonalization. So think of that as taking the ability for somebody who's 3-dimensional and reducing them to 2 dimensions. So it is the knee patient rather than Mrs. Jones. It is the loss of empathy and compassion, you know, that you have, but it is derived through a lot of cynicism. Oh, another Medicare patient. Oh, another Blue Cross patient. Oh, another, and then we can reinforce that as an employer by saying, what's your units today? What's your productivity today? All that drives this negativity and this cynicism around being a PT. Oh, it's another workers' comp patient. So that's kind of a second dimension. And the third is very personal to the therapist. It's that the harder they work, they don't see any progress. They no longer have these sort of long-term goals. It's a sense that they're not making any further in their professional, endeavors. That one's really critical because at the end of the day, it means they have a loss of meaning about their work, and they really start to be down about PT, and they say, man, I don't want my friends and kids and other people going into the profession. And so that reduced personal accomplishment, and all those manifest by a downward spiral. And the way it manifests itself in the clinic is you become less efficient, so you try to outwork it. And as you try to outwork it, it creates more cynicism, more negativity, more depersonalization, more emotional exhaustion. And so that's really the downward spiral that you need to be most leery of as an employer, because when you start to see it, it's not that they're not trying to work. In fact, they're trying to work harder in many cases, but they're less efficient. That less efficiency drives more burnout. So that's how I would think of it from a classical, standpoint. The prevalence, she mentioned the prevalence within the PT, but one of the research things I've dug up over the last few years is how does it manifest itself in PT in terms of the setting? In other words, are home health therapists more burned out than PTs that work in an orthopedic clinic? And as it turns out, the highest burnout rate is actually those that work in skilled nursing facilities. That's as high as 65%. Acute care is very, very high. The third is home health. The fourth is outpatient orthopedics. Early intervention therapists, extremely low burnout. Therapists that do school systems, extremely low. And guess what the lowest is? Our academic friends. They have the lowest burnout. Why is that? We could talk about that as we go on, but autonomy has a little bit of it. Setting up your own schedule has a little bit of it. Progression. There are natural meritocracies in some of those settings that you'll see. That's a good strategy that we'll get into. But I just thought it was important to point out that this is not monolithic across PT. It's very, very, extremely varied.
Yep, and that's exactly, as you said, what we're seeing with the World Health Organization definition. And it's important to define that because you've got to recognize what it is, understand what it is before you can really measure it and see it. So thank you, Lily, for that. And Mike and Elena, you guys are treating hundreds and hundreds of patients, thousands of patients. What do you feel are the drivers of burnout in your clinics? Really just subjectively, what are you seeing as the biggest drivers of burnout?
Well, I'm one of those 50% who is not actively measuring for burnout and for quality of life with my staff. But we have a small staff. I'm one clinic. We've got 5 clinicians outside of myself. I literally just sit down with them and ask. And the biggest things that we're seeing drive it when I talk to my staff are we now have schooling. I have 3 staff members who have gone through one of these programs that are trying to cram 3 years into 2, and they go nonstop for 2 years, and they're in such a hurry to jump into a job to cover these outrageous student loans that they just have been plowing through, go, 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 and really haven't been taught how to prioritize a work-life balance appropriately. The other thing is, again, in line with compensation packages, high student loans. I have some therapists who will work somewhere else on the weekends, so they're never really turning off. I don't know if these are things that you all are seeing as well. And their capacity to truly, these are people who care. Like, how many of you have people who work with you that are in it to help people? Like, there's a certain level of empathy and caring that goes into that. And it's hard to be passionate about what you do and set it aside to leave work at work. So we've had to come up with strategies around technology and actually training our people, like, it is okay to leave work at work. Let's teach you to be better at work so you can not be at work when you're with your family, when you're on your own free time. And the last thing we found that has really helped, that's been both a driver and something that we could use for a solution, is if you are, I don't know how many of you remember when you were a kid and you were playing tic-tac-toe and you would play against an adult or someone else and they would always win. And once you figured out that you just needed 2 corners, that you could win most of the time, it was like you uncovered the secret to winning more often. Now it's fun. How many of you want to get into a sport that you suck at? I know that's not the nice way to say that, but if every day you're like, I'm in this because I care about people and I want to help people, and you don't find that you're particularly successful, that's a big part of burnout for people, not feeling like they are meeting a purpose or having a purpose. So in our clinic, being able to have those conversations, have mentorship, being able to say, like, I got stuck. Being able to have that environment where you can say, I don't know, I need help, where are resources? And being able to get resources is something that my clinicians have brought to me, that having someone that they can just say, I'm blocking this spot on your schedule so you can help me with this patient, has been a big thing to them, not feeling like, sometimes they feel like, am I ever going to learn all of this? You're in your first 3 years. I still don't know everything. I've been out 20. Like, it's always learning, but helping them have that vision that it's a constant journey and not just, I worked so hard through school and now I'm supposed to have it, to where they feel like they're not able to meet their purpose, has been a big component that's been brought to my attention as well. And I have people come to our clinic from other clinics for our lunch and learn sessions, just to get a little bit of that boost in the arm of, hey, we're all still working to find better options. What are more efficient things we can do for our patients? What about those ones that don't meet the rules, so to speak? So having success in what they're doing, whether that's with advancement, whether that's with knowledge base, whether that's with actualization of the patient saying, oh my goodness, no one's ever explained it to me that way before, you've changed my life. Those are the things that tend to drive that purpose and help them feel like, regardless of Elena not spending all the money for my salary and benefits, this is a place where I really feel like I've got a purpose and I can be motivated by that versus squashed.
Perfect. Thank you. And Mike, what about you? What are you seeing as the biggest drivers?
Yeah, I think that workload can be a big driver, but the two factors that I think help combat the feeling of burnout within the teams, communication is a big one, and connection. So I think all of us who are PTs come here, you spend a couple days with colleagues, you feel connected to our organization, the APTA and the PPS, and you go home and you feel a little bit invigorated. You're like, man, I'm connected to something. So I think in our individual teams, if the team member is not feeling connected to the organization, and then you start to feel like, well, what am I doing? Why am I working so hard? And I think with communication is the biggest driver of connection. I think we're all kind of wired to fill in the blank or the void with the negative. And so if you're working hard and you're not feeling connected to your organization or even to your greater profession, and there's not communication going on there, you start to fill in that void with, well, whoever they are, it's all for them. I'm not doing this for me. And we've certainly been able to deploy tools that we'll talk about later that helps connect the clinician to what's in it for them as well. But I think, even at points in my own career early on when we were a small organization and maybe I'm working as a single PT and working hard, and even as a business owner, having feelings of burnout, just this will never change. This is going to be how it is forever. Again, we can fill in that void by communicating and let them know, that there are strategies that are being deployed, and don't leave them out there, to fill in the blanks, on their own.
Right. And looking at the research, there's a lot of research on this and very relevant all now, 2025, 2024. The biggest drivers that they see of burnout in the research is value misalignment and ethical burden, administrative and documentation burden, lack of control or autonomy, excessive workloads and high demand jobs, poor organizational leadership support, and psychological safety, and inadequate recognition and financial reward. So very consistent with what they're seeing in their clinics, and that's what we're seeing in the research. Now, Pedro, why do you believe burnout is so much more widespread now than it was 5 to 10 years ago within the PT industry, and what are the primary driving factors of that?
Yeah, so the last 5 to 10 years has certainly been very interesting, and it's kind of a bit of a roller coaster. I think if you look back at the data from like 2015, 2016, it was an issue. It was already sort of rising as something people were concerned about and talking a lot about. And the pandemic really cranked things up to 11, right? They went up very, very high. We have seen a little bit of regression since then in a lot of different surveys and reports, but it's still higher than we were back in the 2000 teens time. And I think you're going to have a lot of forces, reimbursement, stresses, all these different challenges that are making the work much more challenging for organizations and individual therapists, more demands in some ways from therapists, from patients, that complicates it further. But I think there is a bright spot there, is that I'm also seeing a lot of heterogeneity. There are a lot of differences now in how things are being approached. So I'm hearing now not always the stories of I'm so burnt out, or I have all these people that are quitting and they're just leaving because they don't know what to do. Now there's a little bit of a few gems, here and there, and that where this has been something that organizations have been focusing on now for a while to try to improve, and a lot of technology folks have been trying to help as well because it's such a large pain point. And so now there are some folks that I've heard have come back into the profession because they found a way to do it, either through technology, through special initiatives and organizations that help them, come back and enjoy treating patients again. So I think there is some hope now, but it's definitely not, resolved, and it's going to be still a very complicated problem. But I'm optimistic that we can continue to make some progress.
Great, and I'll look forward to talking about those strategies in a second. Now let's talk about measurement. How should we be measuring this, and what strategies can we do to break the burnout cycle? So Larry, I know measurement is a major challenge, as we see only 1 in 2 clinics are really measuring it. So what tools do you recommend to accurately measure it? And when should this happen in the clinician life cycle throughout the company?
Yeah, it's a good question because, if you want to know that it exists, should you make it very objective? Should you have a KPI around it? Classically, research tools are best put in the hands of academic researchers. And so I think you could make a use case on entry of a therapist into your organization for using either the MBI or, frankly, there's 3 or 4 other tools that are sort of subsets of the MBI. And what they do is they take those 3 dimensions that we talked about that are the classic definition of burnout, and they're subscales, and they just make it easier to assess. So I think you could make a case of those entering your organization, are they already burned out? Because we know statistically there are a number that are, which is kind of sad because you're inheriting folks that are maybe burned out. You may not know that. It may not come out of an interview. It may not come out of all the other unreliable ways we onboard folks. So I think you can make a case for that. I tend to take the opposite approach once they're on board. It's more of a positive psychology approach, which if you look historically at psychology, it was always, the absence of disease and what are the things we can do to diagnose people that are already depressed and have other psychological overtones. Where positive psychology says, what are the things that work to make somebody better and how could I get them more flourishing? And so what does that mean? I think you should, survey your employees annually around engagement. Engagement surveys like the Gallup Q12 or even inspirational surveys. I think we've tried to move from engagement to actually inspiration. And so I think that reinforces your environment and your culture. Whereas if you're going to interview them once a year on burnout, it brings about actually a retrospective, oddly enough, it reinforces the cynicism that can go with burnout. But I also think the warning signs, are they calling in more for, sickness? Can you see it and can you feel it? Having a psychological safe spot around it. I know we'll get into some of the prevention strategies, but that's classically how you would measure it. But I generally take the position that academic research should be with the academic side of things.
And Larry, how often should you measure it? Once a year, twice a year? What do you think?
It's a good question. So I think everybody in the world has survey fatigue. Every vendor you go to as a consumer, you're getting a net promoter score on your experience. I'm sure we'll get one from Prop PT on the party last night, and it was fantastic, by the way, and I'll give it 5 stars. So I worry about survey fatigue of your employees. We do too much of it, but I do believe an engagement or inspiration survey once a year is very, very helpful and subclassify it by job type. And then I think everything else should be a micro pulse, a 1-question survey, maybe done monthly. And we do that a lot. I love micro pulses. You get a really good feedback on how they're feeling, how things are going, and nobody minds filling out 1 question.
Great, thank you. And I put some survey of some different ways to measure burnout and looking at the size of your organization, just thinking about cost and how long it is. So that's up there for you guys. And when we come to now talking about the KPIs or the operational metrics, how do you two feel? What are you looking at in your operational metrics that may start indicating that burnout is happening?
My biggest thing I'm looking at is, one, getting help from my EMR to be able to show me what time people are signing off on notes. If I see people signing off on notes at 11 o'clock, midnight, or having to get up early in the morning outside of hours, then I know they're not leaving work at home. If I look at how people are doing on their time to sign off on their notes, that kind of tells me if they're yep, been there, saw the patient, finished the note, done, they can kind of mentally move on. If their notes are taking them more than a day, 2-3 days, then they're having to constantly keep that in their head of what they did on their last visit. And it's like they're just carrying this burden around until they can vomit it into a note, so to speak. So that's another way that I look at those, but I'm sure you have things on a larger scale.
That's an absolute indicator. It's if we run a missed note report and you see certain names that are always on that report and you know that person is struggling. So targeted intervention. And as Larry was saying, running at least an annual survey, and we do that by role. And we've gotten better at the questions that we ask. I think that there's a trap sometimes, as Larry was saying, where If you're asking kind of questions looking for negative answers, you'll get those answers, and you ask the questions in a different way. But you could sit around as a leadership group or as the leader of your organization and come up with great ideas that you think will be meaningful for your team, but they may not. They may not be. So if you communicate with the team and find out what they're looking for, then you can step in and address those things.
Yeah, so putting all that together, as you said, calling in sick, so PTO behavior, documentation, time to sign off, the quality of documentation, and of course, patient visit intensity. You know, are you starting to see that change for your clinicians? And Larry, research consistently shows that mentorship and leadership development and all of those types of different programs in an organization can also help burnout. So what do you feel as an enterprise leader? What strategies can you put into the system to then again help with the burnout?
So let me take a step back by saying that, remember, this is an occupational phenomenon. And for those in the audience, and there are plenty of you that work in an occupational health setting, and classically you look at the worker, the work, and the work site. You're not going to solve repetitive motion by just looking at the worker. You have to take all three of those dimensions into account. So I think that's the system framework that you have to have. And then from there you can develop, really sound strategies, around it. One is having the psychological safety and having the confidence to say, we're going to teach you the early warning signs of burnout. Not any different than you teaching workers the early symptoms of carpal tunnel syndrome, by way of example. And so having that as a framework is a really, really good idea. I think teaching and reinforcing the therapist self-care, self-compassion, strategies around mindfulness, strategies around pause breaks, and understanding that, having that within an organizational context, I think helps. Understanding cynicism and what we do unintentionally, the consequences of which of driving that depersonalization, using terms like the BI tool doesn't lie, what is your units per visit, just that constant pounding and those reminders of that. Keep in mind that that has an impact. I think one of the things you do unintentionally on the positive side, and I would highly encourage it, is we know that grit reinforces or is a resilient factor against burnout. Well, grit is perseverance and passion for long-term goals. How do we best set our therapists up to understand where's your career now and where are you going? How do you progress in a meritocracy of a therapist to become a master clinician or a board-certified clinician? And all of those things actually are prevention strategies, retention strategies, and they mitigate, burnout within the organizational context of it. And I think the last thing you could do is having a recognition culture and a fun culture which has the unintended consequences of all these positive upward spirals. So, for example, we like to say in our company, we grow together, we laugh, we do meaningful work that impacts lives. You're growing, you're laughing and having fun, you're doing meaningful work that impacts lives. We use a technique that I call remind, and it is the gentle reminder that what our therapists do every day is incredible, brilliant work, life-changing, transformative work. They know that. That's why they go into the profession, but they habituate to it when they're seeing patient after patient after patient, and they forgot what that patient looked like at their first visit. So highlighting those things in either newsletters or reminders or email or something that shows the progression of those patients, it's the subtle reminder to the therapist that, yes, I'm progressing, my patients are progressing, I'm doing good work. So there's a lot of cultural elements to it, which by its nature are somewhat emotional, somewhat hard to define. But those, I think, do move the needle. Early warning, identification of symptoms, having that lens of an occupational phenomenon will really go a long way. So it's the little things. It's death by 1,000 clicks. In this case, it's positivity by 1,000 clicks.
And I think the remind one is really important because, we all know when we have a patient who tells us how much we impacted their lives, that makes us feel so good. It brings us back to why we're in the profession. So the more that the leadership team and the culture of the organization is reminding you of the work you're doing and the positive impact you're having, that takes that depersonalization and it helps bring them back to why they're here, what they're doing. And we always say sometimes burnout is the suck outweighs the good. Well, let's get the good outweighing the suck, right? Looking at that now, Mike and Elena, you have put a lot of tools in place to help with that burnout. And I know you alluded to this earlier. Can you give me some examples of a tool you put in place to help those drivers of burnout that you see?
We've done mentorship programs where we have 2 days a week where I'm in the office as a business owner, but they can block my schedule anytime on those 2 days to help them with a patient. So they'll schedule patients on those 2 days knowing this is someone I need help with. So that's been a useful thing. Also, turning over their schedule autonomy. It's your schedule. If here's what you have for PTO. If you don't have enough PTO and you don't want to be here, talk to me. We'll set up for you to get unpaid time. But letting them know that they have the freedom to do that to their own schedule. Now they've got guidelines around how to appropriately do that, but having that autonomy to manage their own schedule, not having to ask me, can I take a vacation? You're an adult, you're a professional, work out your schedule. And they work it out amongst themselves. They do a great job with that. The autonomy there. The biggest thing I think that's helped with burnout in our last 2 years, and the staff will thank me for this pretty often whenever I ask them about, hey, how is this program going? What are the things here? They're like, please do not take away our AI. Because as soon as Prediction Health came out with Sidekick, which is now it's still Sidekick, but as soon as that came out, we hopped on board. And for them to not be staying after to write evals when it's basically done for them in a way that kind of helps teach them, here's what you're looking for to make notes compliant. So it's both an assistive and teaching tool for us, has been great. And also my newer therapist there's a lot of confusion around billing and coding appropriately. So having resources, and now with Sidekick, it actually just pops up in your note and tells you. Those have been really big things for our team to not be having that paperwork burden of burnout.
And Mike, what about you? What have you done in your clinic? Any technology tools or implementation procedures?
I agree with Elena, and I was speaking with Pedro before. We just deployed the Sidekick across all of our clinicians, and the reception's been incredibly powerful. Even as a clinician still treating patients myself, it's mind-blowing to me. Like, these are tools that I dreamt of, over my 26-year career, and never really thought that they would be there. And I was sharing with Pedro that clinicians in the prompt EMR, there's a bucket called in progress, and that's your notes that are still to be completed. And so many of our therapists have been sending text pictures of a 0 in their in progress bucket, and sharing that I've never seen a 0 in this bucket at this time of day. So that's one tool. Another tool that we moved to an incentive-based compensation model about 4 years ago, and our model that we kind of worked out with the consultant had some pitfalls, and then last year met with Jason Wambald here from Onus One, and the pain points that we had in our own system were all solved with Jason's system, and now to have that system integrated with prompt, and we engaged with them, and so what it's providing for the patient or for the therapist is visibility around their compensation, choice, because it's been a theme of ours to really try to treat everyone like adults. And what that means is we communicate with them and really let them know what is going on in the practice. They have visibility. We're an open book, so they understand the challenges of the business owner, and they appreciate what's happening and why decisions are made. But then coming back to the compensation piece, it kind of works out to where they're running the business of themselves, and they have options if they want to be aggressive, if they want to be more conservative, and then being able to kind of marry that all together and say, hey, we're giving you an opportunity to drive your own compensation, and we're giving you the tools to not negatively impact your quality of life, and to have the compliance tool where we believe data makes any conversation easier. So we have the intel that's kind of scoring therapists on their documentation, and then where you need to target some intervention for a therapist, and it's not, the clinical officer coming and saying, hey, where the therapist is like, why are you picking on me? It's like, I'm not saying this. The data is saying that we need to, help you get better with your documentation. So bringing all those tools together have really been powerful for the clinicians.
And it sounds like you're really addressing those different drivers that we talked about, which is the documentation time, the time to sign off, the financial and the psychological safety. So thank you for sharing those tools that you've implemented. And Pedro, if you can tell us a little bit about the data you've collected with these tools and the pajama time and documentation time and how these tools have impacted some measurable difference in burnout.
Yeah. So obviously, big chunk of burnout is this large amount of work, and then not feel like you're making a lot of progress, right? There's other components, so technology can't necessarily help from like the organizational perspective, but from the workload perspective, we've seen really big improvements. So there's lots of different sort of time things you can think about. You can think about the time it takes to actually do a note. So for something like an initial eval, we're seeing 75% reduction in the time to do the initial. So if it was taking you 20 minutes, now it's 5. There's the time from when you have the visit to when your note is signed off. And for a lot of organizations, they're seeing 1 to 2 days reduction. And there's a lot of folks that do stay within 1 to 2 days for signing off their notes. So it's actually a much larger signal amongst the folks that are, and they exist, that are, days, weeks, behind, where we'll see folks go from being behind 10 days on sign off on average, going down to 1 to 2 days, like a really, really big change, for them. And there's the time, as in the time of day that you're signing off. And if you're doing your notes between roughly 8 and 3, 8 a.m., 3 p.m., sort of regular business hours, the quality of the notes is usually better. I like to joke that the coffee wears off around 3 p.m. and you see the compliance scores start trending down. But they get worse and worse and worse as you go past like 10 p.m., right? So 10 p.m. to 6 a.m., where we see so many notes get signed off. For a lot of typical organizations, maybe 5 to 7% of the notes are getting signed off late at night, right? 10 to 6 a.m. And when we see folks implement tools like these, they're reducing potentially 25% in those late night sign-offs. And again, a lot of really great stories where folks are getting, no more, late night sign-offs, no notes at home. So, but across the whole population, really big shifts in that, which has been really exciting to see.
Right. And thinking about that with the role of technology, as you just mentioned, technology is not always going to help in some ways. A recent 2025 JAMA survey study showed that ambient documentation can cut burnout in half. But there are also times when technology actually adds to burnout and adds to administrative workload. So can you share where technology actually hurts us versus helps us, and what leaders should watch out for?
So it's always really important to remember that technology doesn't always mean good, right? It's a tool. So you can give somebody a terrible hammer, that makes their life much more difficult and is very difficult to use, right? And that's not helpful, right? It was a tool, but it wasn't a good tool. And usually when you start off trying to solve a problem, you end up with a very complicated solution. The things that we find most useful and really great to use are simple, and it usually requires iteratively refining and pushing on the tool to get it to the point where it's a nice, clean, simple implementation. And these tools, right, they can really help, I think, with the workload component. So I'll come back maybe for some things that won't work well, right? But until the tool is refined, and as a person who's helped build tools over the years, I really appreciate the early folks, because they're the ones that help us figure out where the rough edges are so that we can iterate until it is simple enough to help and reduce that workload. But until you get there, if you get a bad tool that those the people building it haven't put the time and effort in to really make it quick and easy to use, it can add to the workload. So if you already felt like you weren't making progress, and then you're trying to document in a system or do things in a way that it takes even longer to do, that's going to make the burnout worse. If the tool isn't capturing certain things. So I'll just mention the AI documentation piece, just because that's the one I have the most experience with, right? But when we capture the information, of course, it has to be medically relevant, it has to be compliant, it has to be high quality. And when people go through content that's thought through well, that maybe appropriately references components about the patient's story, it humanizes a little bit of it too, right? So there's this qualitative aspect into the results that technology is giving you as well. Is it beautiful to use? Is it simple to use? And does it maybe highlight some of the things that make practicing and taking care of patients more fun, right? Their story, not by making the note long, but just like mentioning some relevant, nice details in there. Is it a high quality looking result? We've all built templates over the years, right? Where you just kind of fill things in. I don't think anyone gets really excited looking at a template with some blanks and like some things to remind them to do it. But a well-written note through whatever technology or source it is can be really nice because it lets you understand the person and sort of then makes you not think about, I'm looking at a note, I'm in an electronic system that has all these records in it, but rather I'm understanding what's happening with the patient and how they're progressing their care and improving. So reducing the workload, right? If it reduces the workload, really great way for technology to make things better with regards to burnout. But then things like organizations supporting their employees, their therapists, right? Helping them feel like they have autonomy, all right? So they can feel like they can have some ownership, they can make some decisions, and they can make some progress. And if you have the ability to make a decision, and even if it doesn't work out, just the process of saying, hey, I'm going to try to do this with my patient today. My organization believes in me enough that I can try some things here. Even if it doesn't exactly work, trying something and seeing that didn't work is progress, right? And these are the types of things that it's not a technological solution. This is about the organization, the culture that it's setting up, and supporting folks so that they feel that they can do these types of things.
So really, and I think about back in the day when we didn't have to do an EMR for notes, we were just on paper. It was pretty quick. All of our notes were done, right? I don't know if everybody in this room was back in that era. So sometimes technology can add workload and admin pressures, especially if it's a new tool that's not integrated with your EMR. You're adding a new operational procedure, maybe going somewhere else. So always remember when you're adding that technology, it should decrease admin time, operational procedures. It shouldn't be adding additional measures, or else you're just going to continue to add burnout to them. So talking now a little bit more about like compensation, growth, and autonomy. And Larry, you have written numerous articles on this, and I hope that you guys all have read some of Larry's information because they are extremely enlightening and a lot of fun. And I know this is a driver of burnout. So where do you see right now when our PTs are only they're doctoral trained professionals, but still compensated like just shift workers? How does some of these outdated compensation structures, how can leaders really help to implement different opportunities to help advance that part of burnout?
Well, thanks for asking. I will just say this is sort of a topic related and unrelated to burnout, but it's been my observation over 40-year history that our profession has suffered kind of a complex of inferiority complex coupled with imposter syndrome along the way. And I could cite direct access as the first of that. We fought diligently for that for many, many years. And then once we got it in many states, who were the biggest opponents were our own therapists who felt like they couldn't treat somebody and differentially diagnose and do things. Fortunately, over a span of 30 years, we got over it. And arguably, direct access has been the biggest growth factor of our profession. Our pickleball players and our CrossFit and our GLP-1 patients who all get hurt can call us directly now. I use that as an example. But the other example is we fought to become a doctoring profession. That primarily did not derive from APTA or our profession at large. It came through higher ed and academia as a way to get an additional bite of our tuition dollar. In any event, we fought for it, we got it, and all of our programs are now doctorate professions. But we will not, but for whatever reason, we refuse to act like that professional designation really means something. We don't have independent autonomous providers that are PTs. We have them, and mostly they're all employed under salary ranges. We treat them with a schedule that does not allow them to pursue autonomy, mastery, purpose, become a master clinician, become a partner. In most professions, you have a guide path to go from entry level to master to partnership. We generally don't do that. Every medical profession that I know, and I work quite extensively in the dental world now, they're all compensated based on what they produce. Nobody comes in every day and says, oh, you can't provide quality if you get a percentage of everything you collect. No, you can't. You're going to not be compliant if you know. It doesn't work that way, except for PT. We brainwashed our profession into thinking that we can't do that. Thankfully, through work like what Jason's doing and other folks are doing, we're trying to change it. And I'm not suggesting it all needs to change at one particular time, but our profession has to evolve. And it really hasn't changed from a compensation standpoint since Reconstruction aids of World War II. And so in order to do that effectively, look at other professions that have high burnout. Lawyers, traditional lawyers who bill by the minute and bill by the hour. Guess what? They have a high potential for burnout. PTs have a high potential for burnout, in part because we reinforce the cynicism and we reinforce the dread of, oh, another Medicare Advantage patient, on and on and on, productivity, units per visit, all these kinds of things. And so I think that is a factor. Again, work site, and we have to look at it and as a profession evolve our business models and evolve our clinical models and certainly our compensation models as part of it.
Yeah, and it makes a lot of sense. You know, you come out of the field after school, and you're really excited to be that doctor, to be that autonomous provider and treater. And then a lot of times you go into the clinic and you're babysat, or there's KPIs or metrics, and you're told you have to see this many patients. I know I used to see a ton of patients back in the day, but it's because I just wanted to treat as many people as I could. Nobody was telling me to. So a lot of times it's the internal driver. When you have the autonomy and you have the ability to grow in your compensation, we all know reimbursement is decreasing. So how do you pay therapists differently when they have different certifications? How do you increase their pay with everybody making the same reimbursement from the insurance? Well, some of these alternative compensation models allows you to actually pay them a little bit differently versus how they're producing, how they're doing, and how they are billing for the value of the care they're giving. So, Mike, I know you've implemented different models. Can you give some examples on how that's really helped and where you see the burnout happening and improving?
Yeah, with the compensation model that we've landed on now, and a lot of work done with people on our team way smarter than me, along with Jason, arriving at really a percentage of the revenue that the therapist is deriving. They're sharing in a specific percentage of that, which protects the organization so that, you know, it won't run away and get to a place where it's unsustainable. But the therapist is being rewarded for the work that they're doing. So rather than sitting around and saying, you need to hit this productivity number, it's they're looking at a dashboard regarding their own compensation, and they know the impact of any change that they may have. Maybe they want to take another patient at the end of their shift. Maybe they don't, but they can see what the impact of that does. And if they're more creative and there's more people seeking them out, and they're treating more people, they see exactly what that impact is going to be for their own compensation and their own life. And having the visibility to understand that, they're making decisions that are good for them. And you know, the conversation, as Larry's talking about, it's historically in our profession, it's been like, here's your salary and you should work harder. The conversation at the front end of our process to educate people, a lot of times, because it's different, people, you know, are a little bit scared, but as they understand the model, our retention rate has been really incredible as we've deployed these different tools and given people autonomy to do what works well for them or their families. So, you know, I feel that this is a very exciting time in our profession, and we need to evolve. I mean, the stats are in. You know, there's a shortage of therapists, and there's people leaving, I think, because of the legacy systems that we had all had in place.
And compensation is always a hard conversation to have with your employees when it's not based on data, right? So a lot of times, you know, we just did a survey recently seeing how different practices are, what they're doing with compensation, and are they increasing salaries or not. And overall, there's, you know, about 55% of practices are increasing salaries, 36 no change, 1% are decreasing it. But this sort of takes that away, where you don't have to say, I have to increase your, you know, I'm going to just increase everybody by 1%. It actually allows the clinician to have a little bit more future of where they're headed with salary. So Paige, I'd love to know from your perspective, how do we make sure that we don't get non-compliant where people are just billing more units now? We never want that because moral ethics was definitely a driver of burnout as well. So how do we make sure that this doesn't lead to people overbilling and maintain clinical integrity?
So we're talking about compensation, and we're doing it because it's an incentive, right? And I love incentives. I'm like a super nerd. This is one of my favorite topics, so I'm sorry. So we're setting up one set of incentives, and we're saying, hey, we're worried that people will respond to that incentive, and they will respond too much to that incentive, all right? And I like to say that there's 3 key things for a successful incentive. You have to be able to understand what it is. Compensation, people understand that one. You have to care. People care about their compensation. And you have to be able to see. It has to be visible as it's changing, right? So understand, you have to care, and it has to be visible. Now, we have one force, one incentive pushing us to do one thing. So how do we balance it? Well, we have to have another incentive at least, right? So, and you'll have to be able to understand it and care about it and see it. And fortunately, for some of the things we've built, it's having the analytics, having numbers that come up that analyze the work being done, the notes. So we have the compliance model, we have a CPD insights model as well. And so we can help people track now, like, well, what's the quality of the notes? Are you rushing through them to just like get through care and they're now not compliant and you're having risk? When you're choosing your CPT codes, are you then describing them and justifying them appropriately? And we can run the models and they can scan the results and make that visible, right? So that now you have these 2 sets of incentives, the compensation part, and you can balance it with visibility, however you choose to do so that you can track that, like, okay, we're accurately describing, because that's what we want. We want to accurately describe the work that we're doing and then get paid for the work that we're doing. And some of the things that we see from providing that visibility via the Sidekick and some of the AI tools so that people can see whether or not the AI aligns with what they're saying, is for like the general population of Sidekick users, the alignment usually goes up about 5 to 10% for the entire general population. Now, a lot of folks do a pretty good job of justifying their care. Some folks maybe less so. And so if you look at the worst quartile, we'll see 20 to 25% improvement in alignment with the CPT coding, meaning that what they're documenting in the note and the CPT codes that they're picking with that feedback, because they want to do the right thing, they are then adjusting. So I think that's really the key, is just think about what incentives have I set up, right? How are they going to make their decisions, right? If I'm in their shoes, what would I want to do? But then you've got to balance it so that you can say like, hey, like, that's great. You've done well here. Let's check to just make sure that you've justified things appropriately, that we can have that visibility into this counterbalancing force so that you end up at a good, accurate result and not getting pushed too far in any one direction.
Great. And I know we're running a little bit over, so I do want to, if anybody wants to stay for some question and answers, just kind of want to end it a little bit. But Larry, if you have any advice, or what do you think in the future now is what we really should be focusing on, and what we should be doing to combat burnout? If you could recap for us.
Yeah, I would say in general, I mean, certainly there's the idea of, fewer clicks, more care, leaders who sort of model humanity a bit. If we do all those things right, we'll certainly can have more margin. And can we get more margin, the more autonomous we make our providers, the less management they need. PT is the only profession I know, and look, I'm guilty of all this stuff myself. The way I promoted therapists was I made them a regional manager, took them out of clinical care, paid them more. We got to get rid of that. You need less overhead if you pay your therapists more and make them more autonomous, because they need less management. They need less hand-holding. That's some of the keys, I think, to a future business model. You do that right, you're also going to have therapists that have less burnout, more retention, and you'll be able to grow.
Please feel free to follow up with any of us if you have any more questions. And here's some research if you want to take a screenshot to go look later. So thank you all.